Hello. Good morning, everyone. Welcome to Grand Rounds. Our speaker today comes to us from Emory's Department of Cardiology.
Where are we with the heart failure therapies? So we have actually excellent therapies right now, drug therapies to improve the survival and reduce the hospitalization in patients with chronic heart failure. The problem with these clinical trials is that all of them have been done on patients who are outpatient, and there are and the sine qua non conditions in order for these patients to be actually able to tolerate this medicine is actually that they, most of the time, they will be euvolemic and they will be stable as outpatient. Unfortunately, that kind of evidence-based medicine we do not have on patient who is admitted in the hospital with acutely decompensated heart failure. So really most of the evidence that we have is at most an anecdotal or expert type opinion. So I'm going to make a disclosure that this is whatever you're going to see is my expert opinion trying to put together some pieces of evidence-based medicine that we have together that I think, at least for now, it helps me to guide the management of this patient. So first of all, what is the definition of acute heart failure? The classic teaching is that acutely decompensated heart failure is a disease where somehow the cardiac output does not match the metabolic demands of a body, and is usually associated with volume overload and pulmonary congestion. Truth is, if you look at clinical trials for heart failure, it turns out that cardiac output actually may be normal high in about 50% of the patient and probably is low in under 20% of patients. About 50% of the patient with acutely decompensated heart failure actually have normal systolic function. So what seemed to be actually a common denominator is not so much what happens with the cardiac output. What I would like for you to focus more is what's happening with the cardiac filling pressures. Most of the time, these patients, whether they have right-sided or left-sided heart failure, what they will have, independent of the cardiac output, is actually elevated left ventricular and diastolic pressures, or what we use as a clinical surrogate, pulmonary capillary wedge pressure, or right atrial pressure, or both. So at least for the purpose of this lecture and for at least in what I have been using in the last several years as to guide the management of my patients, I would like to propose to you that really acutely decompensated heart failure is actually acute elevation of either left or right ventricular filling pressures with signs and symptoms of heart failure. So what is cardiorenal syndrome? And cardiorenal syndrome, pretty much, it's in a very simple, super simplified version would be there's development of renal injury, an acute renal injury in a patient with decompensated heart failure. And what is very interesting is if you look across the patients who are admitted for acutely decompensated heart failure, this is the largest national registry we have on acutely decompensated heart failure. Over 200,000 patients. They were followed throughout the nation. And their investigators really did a multivariate analysis, and after they controlled for over 200 variables, they came up with 3 variables that predict the highest mortality in these patients who are admitted with acutely decompensated heart failure. And the single most important actually variable, the most sensitive, was actually a BUN over 43. It was not the creatinine. The second that was important was actually a systolic blood pressure less than 115 millimeters mercury, and the third was actually a creatinine over 2.75. So if the patient comes in the hospital with acutely decompensated heart failure, they have a BUN over 43, they're hypotensive, defined as systolic pressure less than 115, and a creatinine more than 2.75, immediately their in-hospital mortality jumps to 20%. If they have none of this, their inpatient mortality is about 2%, which is pretty much average for anybody else who comes in the hospital. So immediately, the renal injury or markers that we use are associated with worse mortality in patients who are admitted with acute heart failure. How about chronic heart failure, where it's a similar situation? It turns out that if you compare what is the negative prognostic value of a low GFR versus a left ventricular ejection fraction in these patients who have progressive chronic heart failure, a low ejection fraction will increase your odds ratio of dying on long term by maybe about 50%. Okay? However, if you develop worsening GFR, that's about at least to fall higher as a negative predictor than a low ejection fraction. And we're always thinking, oh, yeah, ejection fraction is 20%. This patient is terrible. Let's refer to cardiologists. But what I can tell you is that if you refer to cardiologists when the creatinine is 3, it's very unlikely I can help that patient that much. So really, I would like for you to pay attention more to the creatinine early in the disease than so much to the ejection fraction. So whether you look at acute or chronic, heart failure, really the development of renal injury is a major negative prognostic marker for this patient. So there is a major, and so once you develop that, this marks pretty much, even a patient who has chronic heart failure, the progression to those who have probably a very poor outcome. They are close to end-stage heart failure. So because of all this awareness now of how important it is to preserve the renal function in this patient with heart failure, whether it is acute or chronic heart failure, there's a state-of-the-art paper that actually came out in JACC recently that I wanted to at least make you aware of, that may help us to change a little bit of thinking and may provide us a better vehicle of how to approach these patients with cardiorenal syndrome. And first, for those who are interested, and I'll be happy to give them the paper. But bottom line is that I think we're going to see more of this. So what these several investigators have gotten together who are very heavily involved in these clinical trials with heart failure and renal dysfunction, they've gotten together and they are proposing a new way of classifying the cardiorenal syndrome. So the way they say is that it's very simple. You can have an acute so type 1 will be an acute cardiorenal syndrome. In other words, the heart is sick and the acute heart failure is causing the acute kidney injury. The type 2 will be the same, but in a setting of a chronic. So you have chronic heart failure that progresses, and then you develop progressive renal insufficiency. Type 3 will be the opposite. So you have renal disease that's acute, causing cardiac dysfunction. 4 will be chronic renal disease causing heart dysfunction. And the last but not least is really the authors are aware that unfortunately, as much as we try to think as heart and kidney as a disease, there are many other organs in the body, and unfortunately a lot of times systemic illnesses can cause both the kidney and the heart disease. And basically that will be the type 5, and systemic illnesses causing both kidney and heart failure. And a perfect example is sepsis with gram-negatives bacilli. So while this is wonderful as a logical classification, and at least as an attempt to try to subsequently design clinical trials to test hypotheses, is not very useful when you have to handle these patients every day. So what I wanted to do is start with this backbone, and then I'm going to attack 3 of these syndromes, and I'm going to give you at least an example, try to set forth some mechanistic insights that maybe will help us subsequently help these patients. So first of all, in order to be able to help these patients, we have to understand what is really the mechanism for this. How is heart failure causing renal injury? And the simple answer to that is that nobody knows. Of course, we have some evidence for various mechanisms here, and I hope I will convince you that at least some of these mechanisms are way more relevant than others, and I will show you that. So I'm going to talk first about the acute cardiorenal syndrome, basically acute heart failure causing acute kidney injury, or acute renal insufficiency, or acute renal failure. So I like to separate them actually from the mechanistic standpoint, how the heart can affect the kidney, into a left heart failure causing acute kidney injury versus right side heart failure causing kidney injury, or maybe a combination. And I hope I'll convince you that the mechanisms, although some of them are in common, they're a little different. So first of all, so when I say left side or right side heart failure, to begin with, what really affects negative the renal function, it's actually the elevated left-sided pressures, wedge over 80 millimeters mercury, and whatever objective evidence we have about that, or versus right-side heart failure, elevated right atrial pressure over 15 millimeters mercury. Most of the time, the clinical presentation of these patients are somebody who's admitted with acutely decompensated heart failure, and despite your best attempts, you find that is worsening renal function with attempted diuresis, despite obvious fluid overload. Obvious the patient is still decompensated, still needs fluid to be pulled, and develops worsening renal function. And of course, this is usually patient usually it's cold and wet, and And what is really interesting, if you just send a urine analysis, we do this all the time, you'll always notice that there is what we call a pre-renal azotemia picture. The BUN creatinine ratio is over 20. The kidney is an avid sodium retention state, does not let go sodium from the body, associated with the urinary sodium less than 10 milliequivalents per liter or a phenol less than 1%. The UA is kind of blind. You don't find many cells there. And was really it's a non-oliguric acute renal failure most of the time, at least initially. And was really important to differentiate that from ATN is that the kidney still has the capacity to concentrate, so the urinary osmolality is over 500 milliosmol. And so I will show you an example. About 76 years old, African American female who was admitted for 2 days of worsening dyspnea, orthopnea, and PND. She was living in nursing home. In nursing home, she was only on Lasix 40 once a day. Her blood pressure is 110/82, which even if the systolic pressure is kind of low, notice the pulse pressure, which is the difference between systolic minus diastolic divided by systolic. If it's less than 25%, that tells you that you have really very low cardiac output, low stroke volume. That's actually pathognomonic for low stroke volume. The diastole is actually inappropriate high for this patient. She's tachycardic, obvious as volume overload with elevation of both left and right side pressures, and cold and clammy, which means the systemic vascular resistance elevated, is hypoxic, and for the initial renal function shows a BN of 32, creatinine 1.4. Despite actually receiving 40 milligrams IV of furosemide in the emergency room, she only had a 200 milliliters urine output. And 12 hours later, actually, her renal function gotten worse. So the X-ray shows pulmonary edema. Echo shows a dilated cardiomyopathy with an ejection fraction of 15%, but the right ventricular function is normal. So if we swan this patient, immediately we notice that she's got a low cardiac output, has severely elevated systemic vascular resistance, so a normal range, normal value would be about 1,000, so it's 3 times higher. Has got pulmonary hypertension with clear elevated wedge. So really elevated, what we see here on the hemodynamics, elevated wedge, elevated systemic vascular resistance, and low cardiac output. So this is a typical example of advanced left-sided heart failure. So she has renal insufficiency, and my question is, when I see these patients, which one of these following mechanisms are going to apply for this patient that I can intercept with therapies that I can help to avoid development of renal failure? Obvious, we need to diuresis this patient who's in pulmonary edema. If I cannot get that kidney better, all bets are off. So I have to do something to improve the renal function and improve the diuresis. So do we think that the low cardiac output is so what I put here, what is the key mechanism? What I mean by key mechanism, probably that's the main one that started the whole process. And of course, subsequently, one other mechanism can occur and then multiple can coincide. For example, it's obvious that this patient has low cardiac output that will further contribute to renal dysfunction. But because this patient is only in the hospital now and has had a low ejection fraction for 10 years, if that will be the main mechanism, she should have been in the hospital for the last 10 years. Obvious, this came only subsequently, and something happened. That is not really the main mechanism why she's developing renal insufficiency. Is it that she has intravascular depletion from diuretics? And I think that's an incorrect statement. It's impossible to do that, because if you have volume overload and interstitial fluid, that comes after you already expanded your intravascular space, at least in patients with heart failure. So that's not the case here. Could she have renal vein hypertension? What I mean by that is if you have a right atrial pressure, it's over 20 millimeters mercury, the pressure gradient across the kidney bed is going to go down because the renal veins, they do drain in the right atrium. That by itself actually can be a contributor to renal insufficiency, and I'm going to show you, particularly in patients with right-side heart failure. Relative intravascular depletion from low cardiac output with extravascular volume expansion. This is a concept that our nephrologists definitely see every day. But they see that in the dialysis place. This is when they need to pull off 3-4 liters in 3-4 hours, and there's tremendous shift of the fluid from intravascular space that needs to be re-equilibrated back from the extravascular space. I can tell you that very rarely I have seen this occurring in a patient who is not on dialysis. Sure, if they bleed in the same time when we are diuresing them, but most of the time, or if you diurese somebody who has absolutely no peripheral edema and their main fluid is in the sides, in the peritoneal pleural space, where you are limited by peritoneal or the pleural reabsorption space. So I would like for you, this is a virtual reality outside of the dialysis. Sometimes it's actually very hard for me to convince our nephrology colleagues to believe that. Now, inappropriate renal vasoconstriction. I hope I will convince you that no matter what, if you have heart failure and you have cardiorenal syndrome, it's absolutely, it's mandatory that you have to have renal vasoconstriction, and I will show you data for that. This is actually the main mechanism why this patient developed pre-renal azotemia. Hypotension, yes, that can occur. We know that in order to have adequate renal perfusion, you have to have a mean arterial pressure of at least 65 millimeters mercury. So if somebody is hypotensive, particularly from heart failure itself, that can definitely occur. But if you look back at this patient, the mean arterial pressure of this patient is 100. So it's obvious this is not the case here. So you can immediately rule that out. Also, another issue, if you have pure hypotension-induced renal insufficiency, what's going to go up is actually the creatinine, not so much the BUN, or a little more like early ATN. Sepsis, or what I call systemic inflammatory response syndrome, the one that actually can cause peripheral vasodilation and can drop the mean arterial pressure enough that will go below the renal perfusion level. Again, we have no evidence for that, at least on this patient. This patient's cold, clammy, wet, looks like more of a pure heart failure. So let me see if let me show you the evidence for renal vasoconstriction here, because that's what we need to attack, or at least what I do every day. This is a study that was done in humans. There are not many patients. There are about 30 patients who were admitted with acute decompensated heart failure. They had actually Swan gas catheter placed. And these patients, they were separated in 3 different groups depending on what's their level of the cardiogenic shock, depending on invasive hemodynamics. So for example, and then they did very accurate measurements of their renal function, renal blood flow, and renal vascular resistance. So this is actually very fascinating. Look at this, if your cardiac index is more than 2, all right, if we look at the renal perfusion, the worse the cardiac index, the worse the renal perfusion. So that's what we thought. Clear, a kidney that, develops renal insufficiency from heart failure, you would expect that you have renal hypoperfusion. So that's obvious, a universal mechanism. But what's really, I think, fascinating is that this kidney not only that has low perfusion for whatever reason from the heart, but actually it's building up resistance to it. It's actually have inappropriate, what I call renal vascular resistance. So this mechanism actually is completely deleterious. It makes no sense if you have a poor perfusion for the kidney to develop some mechanism that will fight against that, all right? So this is actually very intriguing. A similar concept, for example, in pulmonary disease, if you have hypoxia, actually the bone marrow will upregulate, the red blood cells to extract more oxygen if you have hypoxic condition. That seems to be exactly opposite here. So in other words, it's not just that I have renal hypoperfusion, but the kidney has some weird mechanism that fights against that by inappropriate upregulate, increasing the renal vascular resistance. And what's fascinating, if you look at our usual clinical markers to try to detect that early, it turns out that really creatinine actually changes only very late in the disease. And if you look at GFR actually is, according to the BUN or creatinine, it's actually preserved until very late. So if you have acute heart failure and really cardiac index less than 1.5 is cardiogenic shock, actually your GFR starts to go down only after you have an index less than 1.5. But meanwhile, the BUN starts to go up. So it's very fascinating is that if I have all these different markers, the most sensitive appear to be and correlate the best with actually the degree of renal hypoperfusion and renal vasoconstriction. It's actually the BUN. So the way I see it, I'm going to look at this patient's BUN to really figure what's happening, how vasoconstricted the kidney, and how bad is going to be the renal failure. And if I look back at the retrospective analysis that I was showing you, no surprise that elevated BUN was the most important negative predictive factor for this patient with acute heart failure. And indeed, those groups who have elevated BUN, also they have elevated not only left-sided heart pressures, but also right-sided pressures. So renal vein hypertension seems to be an important element here, okay? So I have a question for you. So now if we have clear the background of these patients that before we even hit them with furosemide, when they come with acutely decompensated left-sided heart failure, they already have tremendous renal vasoconstriction, plus minus low cardiac output. Now I'm giving them 40 IV of furosemide, and paradoxically, this is getting worse. And why is that? So I will need to show you is that not that the patient doesn't need diuretic, but it's how you do it that makes a difference that can improve the outcome. So this is a study where they actually, Dr. Stevenson, who is really a leader in acute and chronic heart failure from Harvard, she showed that actually if you swan the patients with heart failure, acute heart failure, and then you give them only a furosemide IV, look what happens with the stroke volume. So the wedge pressure is going to go down if you diurese. However, immediately the stroke volume is going to go down. So it's very interesting. IV diuretic is going to cause low stroke volume and therefore low cardiac output just by that. So on one hand, we have benefits with the diuresis. On the other hand, we're going to diminish the cardiac output just from that. However, if you use it concomitant with nipride, for example, it turns out that you get best of both worlds. So you get both your wedge going down, but also actually the cardiac output going up. Okay, so if you just were to use diuretic alone without an appropriate vasodilator, probably you're going to be deleterious. But if you use this with vasodilator, that can help. All right, let's dig a little bit into why the loop diuretic per se in somebody with heart failure actually worsens the kidney function and the heart failure. So if you just look at the GFR and you give somebody 80 milligrams IV of furosemide, the expected urine output is going to be, they're going to pee about 3 pounds or 1.5 liters in about 8 hours. So that's normal. Of course, this assumes this is a patient who obvious response to it, so it's not that advanced heart failure. The sidekick of it is that actually the GFR is going to drop by 25%. Now remember that the kidney is the most wet organ in the body. It does not tolerate any drop into of its perfusion. So this is actually a tremendous insult on the kidney. Even this may not cause immediately an elevated BUN and creatinine. So this happened very early in the disease. So what happens is, if you swan all these patients, this is a study with about 70 patients with heart failure who actually had invasive hemodynamics, resting invasive hemodynamics, and also the levels of neurohormonal activation. And then they were given 10 to 20, they were giving IV furosemide 40 milligrams. And then they were measured again all these hemodynamic markers and neurohormonal activation 10 to 20 minutes IV after furosemide. Okay, look what happens. The wedge, which obviously was elevated, goes up to 33. So this makes no sense. The stroke volume tends to go down. The mean arterial pressure, instead of going down like I've been taught when I was a house staff, it's actually going up. So intravenous furosemide in patient who actually has acute heart failure and neurohormonal activation does not drop the blood pressure as long as they have volume overload. Of course, if you dry them out 5 liters later, that's a different story. I'm talking about acute when you're still considered it's indicated to give furosemide. As a matter of fact, and me and you will cause that because we will cause immediate venodilation effect within 10 minutes, and we will become hypotensive. But in patients who have revved up neurohormones, will cause actually paradoxical neurohormonal activation. So notice the systemic vascular resistance goes up. That's why the mean arterial pressure goes up. And this is solely due to actually inappropriate elevation of neurohormones that causes vasoconstriction, such as angiotensin II and norepinephrine. So I'm causing with the diuretic more neurohormonal activation, which then increases the systemic vascular resistance, which just drops the cardiac output and vasoconstricts the kidney and worsens renal function. So that is probably a very important mechanism for these patients. So if you were to just use IV loop diuretics, particularly each time you use it, frequent Q8, Q6, each time you do that, you're going to activate the neurohormones. So you're going to reproduce in short term. What we have learned is deleterious and bad for you in long term in heart failure. So going back and how the diuretics in this patient may cause actually renal insufficiency, if they were used that way, the way we learn in emergency room as a first act for this patient. Number one, remember that a kidney that is working in the context of acute heart failure will be tremendously underperfused, will be vasoconstricted. Actually, the inner medulla is going to be very ischemic, so the loop inhaler doesn't see a lot actually of blood flow. Then most of the blood flow will be preserved actually in the cortex, where you have the proximal and the distal tubule, and that's because of the norepinephrine, angiotensin, and vasopressin activation. Okay. if you give, and this is why, because you have this vasoconstriction, then most of the reabsorption of the sodium and the water will happen not so much in the loop of Henle, but in the proximal distal tubule. So therefore, you're going to have, and the kidney will be in heavy sodium retention state. So because this is no longer working well, this is working extra, you're going to have actually sodium and water retention, and that will expand the intravascular volume and further elevate the cardiac filling pressure. But the second thing that happens is that in the BUN, once you reabsorb the sodium, the BUN gets concentrated in the tubule. And actually, through the pressure gradient, BUN starts to be reabsorbed from the proximal tubule too. So really, that's why we have an elevated BUN and creatinine ratio of 20. So each time I see this, I think renal ischemia and vasoconstriction. And I think that the higher the BUN, the worse is my proximal tubule reabsorption, and the worse is the vasoconstriction. So I want you to make this connection, at bedside when you look at these labs. The second thing is that now I'm going to hit with the loop diuretic. Well, first of all, the medulla, it's already ischemic, so you're not going to have a lot of loop diuretic penetration. So we know that you really got to use, you might as well, if you were to use a loop diuretic, don't use 20 or 40 or even 80 sometimes, may not do the job. You really got to use much higher. As a matter of fact, probably 80 will do the job of a 20 in a normal condition. The second is, you are going to, when you're going to block this here, you're going to enhance even more these effects here because you release more of the angiotensin and all the neurohormonal activation, okay? So you're going to aggravate this if that's the only way you're going to do it, okay? What take-home message to wrap this up, how left side heart failure will cause you renal insufficiency is, for whatever reason, initially insult being elevated left-sided pressure, elevated LVEDP, the left side of the heart gets stretched, activates all these neurohormones, which that activates tubular and reabsorption of the sodium and vasoconstriction, both systemic and peripheral, okay? And then that together will further reduce the cardiac output if that continues. And then if we just use diuretics, we're gonna do the same thing, okay? So what I would like to propose to you is that, number one, no matter how we do it, even the therapies that we use to help this patient, we actually work on as a main concept on an inappropriate renal vasoconstriction. And that means if I want to treat this patient somehow, I need to improve the renal perfusion and relieve that before I'm able to actually use the loop diuretic. So what we have learned from the clinical practice, and again, there is no clinical randomized trial that I can prove you with this, but if the patient is volume overloaded and is cold means really, in general, means that the patient has elevated systemic vascular resistance and may or may not have low cardiac output, then the diuretics will increase actually mean arterial pressure and worsen renal function. Unless, and it's associated with pre-renal azotemia, unless I'm going to first do something else. So first we need, before we hit them with diuretic, recognize that they're vasoconstricted. And you need to normalize the vasoconstriction and improve the cardiac output before you hit them with diuretics. So I always first start the vasodilators. I make a judgment. Some of them may need inotropes, but I do that before actually I give the diuretics. And of course, just using a vasodilator doesn't mean anything. We have some of them, my vasodilators are milder, some of them are, stronger. You gotta use the vasodilator that will get the systemic vascular resistance to the goal. And how do I know what's the systemic vascular resistance to the goal? Well, a surrogate, really, systemic vascular resistance, there are two numbers that get into that formula if I were to do a SWAN. One is cardiac output, the other one is mean arterial pressure, okay? I do not like to use systolic blood pressure as a bedside to actually tailor the vasodilators, because the mean arterial pressure, it's 1/3 systolic blood pressure, 2/3 diastolic blood pressure. So if I were to use just systolic blood pressure, I'm going to be correct 1/3 of the time, and I may inappropriately withhold vasodilators somebody who actually needs them. And the other way around is correct too. If I go just by diastolic, only 2/3 I'm correct. If I go by mean arterial pressure, we know from all physiology studies that a good mean arterial pressure for a patient with heart failure, it should be more than 65 because that's adequate for renal perfusion, but it shouldn't be any more than 70. They need to be tuned up there because anything higher than 70 will mean a systemic vascular resistance over 1200. That means I have too much afterload and I need to use vasodilators. So I'm going to use whatever it takes to get that map close to 70 as much as I can. Then some patients doesn't work. I might need to use a Swan-Ganz catheter to optimize hemodynamic, but particularly if they have renal dysfunction. What we learned from the clinical small, randomized clinical trials is that actually continuous IV loop diuretics, long-acting and higher dose are better than short-acting, frequent, and low dose. Remember that with each time you give a diuretics, even 20 IV of Lasix will activate the same neurohormones as 120 or 200. The difference, the 20 will give the insult, but very little diuretic response. The 200 will give the same insult, but at least you'll have appropriate urinary response. So you shift your therapeutic to side effect ratio towards beneficial effects. And then, so actually, despite of what being taught traditional, I felt I'm going away from going higher on the frequency of the diuretic, but actually rather using higher dose and then, or like more like drip, and then actually use it only once a day. All right, so what vasodilators we have? I don't have time to go over in details how and what's the approach. Well, I can tell you there are some of them are milder, some of them are more intermediate potency, some of them are very strong. Really, the purpose of a vasodilator before anything else is to improve the systemic vascular resistance. Remember, cardiac output is a dynamic function of systemic vascular resistance. For somebody who has had a EF of 10% for 10 years, they have normal cardiac output. That's why they're not in the hospital. They only drop the cardiac output after, for some reason, for whatever stressor it is, it's inappropriately elevating the systemic vascular resistance and causing neurohormonal activation. Then immediately cardiac output goes down. All right, so fixing first the systemic vascular resistance already can triple your cardiac output, and you don't necessarily need to use an inotrope. That doesn't work, of course, you may want to add an inotrope. And I reserve inotropes only for special conditions and settings, and I will tell you about that. So the rule of thumb strategy for this patient is, number one, if they have cardiorenal syndrome, to begin with, be aware that this is a very sick patient, much sicker. It doesn't matter how clinical noisy looks the patient. You have renal failure is bad news. Pay attention to that. Number two, first, I would fix the high resistance, systemic vascular resistance that's going on there. I would first use a vasodilator, and I would go to a goal to really use the potency and the frequency that will get the MAP as close as possible to 70. Second, then I'm thinking about using a diuretic. After I prime, I vasodilated the kidney, I improve the cardiac output, then I can use my loop diuretic, and that will be okay. And how and what type and what dose and what's the setting, that's a different story, depending on the patient, on prior renal function, and everything else. And then I only rarely use inotropes and only short them, and that obvious when you cannot use a vasodilator. If the patient has heart failure, is cold and clammy, has a mean arterial pressures under 65, I cannot use vasodilator even if I want to. So I'm gonna start the inotrope there. And each time they have a worse renal dysfunction, despite of me already having them on optimum vasodilator dose, or the patient is septic with systolic function, obvious this is gonna be in a warm and vasodilated patient. Vasodilators will be the worst you can do to these patients, okay? So going back to, so I hope I convinced you that the main mechanism, one of the essential key mechanisms, and actually in patients with acute cardiorenal syndrome due to left-side heart failure is actually renal vasoconstriction. And vasodilators are the key players there before you use a diuretic. The second one I would like to show you is an extra mechanism that occurs when patients have actually severe right-sided heart failure. In other words, inappropriate elevated right atrial pressure. So this is a typical patient has 64 years old, has history of sleep apnea, has severe hypertension with acute decompensated heart failure and anasarca, severe pulmonary hypertension, recurrent emissions for volume overload, orthopnea, PND, over 40 pounds fluid above the dry weight, obvious severe elevated right-sided pressures. It's got some low pulse pressure, suggesting cardiac output is not normal either. The EF is normal. The left side is okay. It's got some mild LVH. The problem is on the right side. And the baseline BUN and creatinine were 22 over 1.4, and then it has increased to 66 over 2.2. So from what I taught you before is that the BUN and creatinine ratio being over 20, the higher the BUN, the worse and the more vasoconstricted is the kidney. That's how you need to think. That just because we're used to that, BUN indeed is not a good predictor of irreversible kidney damage. Creatinine is good for that. That's what our nephrologists know. But for acute decompensated heart failure and for acute sedating in the hospital, BUN tells you more of what's happening in terms of renal vasoconstriction. And sure, if you can reverse the BUN, you're still at the reversible stage. That's all it means. So again, what's the mechanism here? Well, here I'm going to try to convince you that not only we're dealing with inappropriate renal vasoconstriction here, and low cardiac output maybe, but really this is all triggered in the absence of a problem with the left side. Really, the ejection fraction is fine on the left side. The main problem is actually everything is started with the renal vein hypertension, okay? So the kidneys don't only have arteries, but they also have veins. So let me see so the clinical scenario, what happened with this patient, I was consulted on a few weeks after all this started. Basically, initially, the urine output dropped to less than half a liter a day, despite actually going up on Lasix to 80 Q8. And I showed you why that can occur. You activate more neurohormones without preparing the patient. Now, then this was held, the butamine was started, thinking that you gotta help the right ventricle. Then you add the hydrolyzine and nitroglycerin to help improve the right side preload and afterload. However, that did not improve the renal function. The BUN creatinine continued to increase to 88 over 2.9. Then nephrology renal was consulted. Pretty much the workup shows that this is consistent with the pre-renal azotemia. However, the nephrology service interpreted this as the kidney is dry, and we are dealing with an intravascular depletion on the intravascular side and extravascular volume overload, so-called third spacing. And they stopped the furosemide, receive a bolus and normal saline, and I always say, well, you can have any theory you want. If the patient is getting better, then that's fine. The problem is that next day, actually, urine output got worse, and actually the kidney got worse. So obvious what was missing with this patient was not the fluid bolus that he got, but it's something else that was the main mechanism that was missing here. Okay, so this is an example of an echo of that patient. What I wanted to show you is not for you to become an expert with echo, but there are things on the reports from echo that can help you tremendously actually to understand the physiology of this patient. So look at this left ventricle, it's banging. EF is over 60%. The right ventricle is huge. It's hypocontractile, it's barely moving, with the interatrial septum bulging into the left atrium. There is severe pulmonary hypertension according to tricuspid regurgitation jet. And this, if you look careful, this is what we call the subcostal view with the inferior vena cava. It's dilated. And all the blood flow you see is red, the transducer is here. That means all the blood goes away from the heart towards the liver, which means there is no forward flow towards the heart. If you have no forward flow to the heart, that means the pressures are so elevated in the right atrium that everything stays in the splanchnic territory, including your kidney blood flow. So this is an issue in these patients. And these studies actually have been done as early in 1930s. So I thought I'm the one that, I'm discovering something there. And I went back, and first I found this little study. I was asking the question, is there any effect of really renal elevated right atrial pressures themselves on the kidney function? It turns out that indeed these studies have been done initially here in dogs. It was published in Lancet. It was a small, one-page publication. They show that actually if you clamp, you increase the right atrial pressure by clamping the IVC, you suddenly have a drop in the GFR once your estimated right atrial pressure goes below higher than 20. So GFR is normal, then suddenly, boom, drops once you have your right pressure over 20 millimeters mercury. That will be equivalent in the clinical scenario, somebody who has a JVP up to the earlobe, okay? So that's interesting. That by itself drops the renal perfusion, okay? And then more recently, actually, in 99, the nephrologist actually associated with the abdominal surgeon. And what happens is in the general surgery world, there's a syndrome called abdominal compartment syndrome, where if you have an abdominal surgery and you have fluid accumulation or something happened, you can actually create renal vein hypertension from the increased abdominal pressure, and that can cause renal insufficiency. So actually they created a model where in pigs, they actually clamp down the renal vein by increasing suddenly the renal vein pressure to about 30 millimeters mercury, which is not infrequent what we see with this patient with severe right-side heart failure. And they study this acutely within 2 hours. Look what happens with the kidney function within 2 hours. Immediately, once you go your pressure up to about 30, within an hour, your urine output drops to a third of what it was. So kidney immediately stop peeing, okay? And they start, not only that, but you start to retain salt, okay? And it stays like this as long as this diary pressure, the pressure is high. Then as soon as you release the clamp, it gets back to normal. And what's very interesting is that you think that there's plenty of blood into that kidney, but the amazing thing is actually the renal blood flow immediately drops out. So in other words, the kidney is finding some mechanism again to resisting the blood flow, and it's causing renal, developing renal vasoconstriction, and that correlates with the GFR. And why is that? Well, let's look at the usual culprits in heart failure: neurohormonal activation, angiotensin 2, renin, and voila, that's exactly what happened. The aldosterone goes up, the renin-angiotensin goes up. As soon as you relieve the clamp, goes back to normal. So even if you have a perfect normal left side, normal cardiac output, just elevation of the right atrial pressure over 20 millimeters mercury causes disease by itself by activating inappropriate renal vasoconstriction. The same mechanism that you have in left side heart failure, but actually it's just worse. Okay? And of course, if I would like to treat this, what I need to understand is that a right side heart failure kidney is actually worse than the left side heart failure kidney. If I always said if I will ever get either left or right side heart failure, if I could choose, I'm going to ask God to give me left side heart failure. Okay? The reason is here you have a perfect normal left heart. You get your eye pressure over 20. You get renal vein hypertension. Immediately the kidney will vasoconstrict inappropriately, will strangulate itself. The renal blood flow towards the kidney will stop. Because it will eventually, initially, these neurohormones like angiotensin 2 and norepinephrine will just vasoconstrict the efferent arteriole. But then at a higher level, vasoconstrict the afferent too. So actually, you have inappropriate even renal arterial vasoconstriction. And then the urine output will drop. And what's fascinating is that with the aldosterone release, aldosterone chronically will start retaining salt and water in the body. What's the consequence of that? Well, you're going to expand even more the intravascular space, and you actually elevate even more the right-sided pressures. And eventually, if you keep doing that, you're going to elevate the left-sided pressures too. Your wedge is going to go up, and then you develop left-sided heart failure too, even if systolic function is normal. And eventually, if you continue, you're going to get low cardiac output on the left side too. So this is bad. And this actually, it turns out, it went all the way back to, it was published in 1931, very old, classic, paper that pretty much proves the concept that renal vein hypertension or elevated right atrial pressure, it's a disease by itself. And because most of the time this is caused by actually volume overload from the right side and everything else, to me, the take-home message is volume overload in these patients is a disease, causes renal vein hypertension and everything else that we learned. And then the opposite was true when the authors actually relieved the clamp or diuresed tremendously the patient. Here, actually, this patient, instead of stepping back on diuretics, what you need to do is actually the opposite. You need, one way or another, remove the volume to reduce that right atrial pressure. So actually, when they went up, but you have to understand that they are more diuretic resistant, so you have to use 2-agent, some other vasodilators. If you do it that way, actually, and you keep doing it for days, this is the cumulative. Over 25 pounds fluid removal, actually the creatinine comes back to normal. Okay? And so number one, the elevated right atrial pressure and renal vein hypertension causes the inappropriate renal vasoconstriction and dysfunction. Number two, a heart that gets from those mechanisms more and more volume overload and stretch, instead of functioning on the proper curve of the Starling curve, will function on the downslope of the Starling curve. So I'd like to, just to refresh your memory, and really this I see in my mind every day at bedside. Basically, the Starling curve dependency says that for a given ejection fraction, let's say a normal ejection fraction, the higher it's your preload, that means the more stretch is the heart, or the higher is the wedge, what we do every day, then the higher will be the cardiac output. But once you get below 18 millimeters mercury, somebody who has normal EF, then the cardiac output is going to start to go down, and you're offload, so to speak. However, in somebody with normal EF, if this happens acute, we'd actually never get to be here, because once your wedge is over 18 and you're acute, you're going to pulmonary edema before that pressure goes up. But if your EF starts to drop, like our patient with chronic heart failure, ejection fraction like 35%, 20%, their Starling curves are very different. They're more plateau and they're shifted to the left. So now if you look very careful, the same wedge that will be here about 18 millimeters mercury, that will be an optimum for somebody who has a normal EF. Actually, the patient is already functioning on the downslope of the relationship between cardiac output okay, and the feeling. So in other words, if I want this patient, a right ventricle or left ventricle, the stretch needs to be unloaded. We need to drop the cardiac filling pressure to actually increase the cardiac output of what's happening. So this explains the positive vicious circle, why stretch of the heart and elevated cardiac filling pressure causes more neurohormonal activation, which is causing worse cardiac output, and it keeps going until you actually unload that heart. And right ventricle is actually worse because it's an elastic, compliant ventricle. Is actually from the beginning behaves more like an EF of 20% or less as opposed to 35 or the other. So it's more flat and more shifted to the left. The right ventricle, it is said traditionally, is more preload dependent, but it's also more afterload dependent. So actually narrows the limits where it can function properly. So you really got to keep them where they need to be. Okay, so this patient actually, I put her on a vasodilator. It's excellent for the right side of the heart with high dose diuretic actually. Torsemide, at that time we had it IV and with diuretic. And these patients, if that doesn't work, you might need to do ultrafiltration. Actually, diuretic is suddenly from 500 cc's a day, 5 liters a day for 5 days. And lost all that, BN and creatinine came down, and she was discharged on PO diuretics. Of course, if you don't treat the underlying disease, that doesn't do much. But in summary, what I wanted to show you is that whether you have left-sided heart failure or right-sided heart failure defined as elevated left-sided pressure or right-sided pressures, eventually lead to inappropriate vascular resistance, elevated vascular resistance, and renal vascular, actually vasoconstriction, and sodium reabsorption. And then with diuretics, you're going to enhance that unless you pre-medicate first patient, improve the hemodynamics condition with either vasodilator plus minus inotropes. And how do I know? You say, well, you keep talking about neurohormones, but we never measure this in the clinical practice. How am I'm supposed to know who is this patient and when how I need to use vasodilator? It doesn't mean that when everybody comes in the hospital with heart failure, we got to put them on vasodilators before you give them diuretics. So the way you identify them at bedside is, first of all, simple things. If the patient is cold and wet, cold means chances are systemic vascular resistance is elevated, and then you look at the mean arterial pressure. If it's over 80, you know that if you were to swan this patient's high. Wet, obvious, it's got volume. Volume that's in an interstitial space comes from intravascular space. You cannot in heart failure have that without having a stretched heart. So that by itself, it tells you that you have that. Other clues that we have that we have learned from clinical trials is, number one, the higher the BNP level, that means the more chronic you have the elevated LVDP, the most likely you're going to have chronic neurohormonal activation. So keep that in mind. Even on a BNP level of 1,000 where somebody appears relatively asymptomatic, it's bad news. You know they're going to be in the hospital or they will be worse. And doesn't mean we should treat it, but it will tell us what's happening. Second, of course, development of hyponatremia. We know that's a bad marker in patient with heart failure. All it means is that you have elevated neurohormones, and this happens only in advanced stages of heart failure. And really, particularly the vasopressin will inappropriately retain the water. And what things that actually are more important that we see every day and are up to us, and from the echo report, number one, clues for the elevated right atrial pressure over 20. JVP to the earlobe. It doesn't matter whether the patient appears volume overloaded or not. I want to remind you that somebody who has right-side heart failure, particularly advanced heart failure, they will retain first up to 20 pounds of fluid centrally before it goes peripherally. Particularly if they're on high-dose diuretics. So clinically, you're not going to be able to, there will be no rails on the physical exam, the x-ray will be clear, but the symptoms of the patients will tell you what's happening. They will have actually early satiety, they can't eat, they're not going to absorb their pills, all they do is absorb the sodium and the water from the stomach. So unless you pop the question, they're not going to tell you. They'll just have, a lot of times they'll have a lot of GI workup for no reason in the ER and nobody will know why, all right? So that all it means they have liver congestion. And on the echo, what correlates with this, and it's pathognomonic, that's my personal observation, you have a dilated inferior vena cava with a systolic flow reversal on hepatic vein, what I just showed you. So please pay attention to that part in the echo report if you see it, because this tells you this patient's function already with cardiorenal syndrome. Doesn't matter what's the BN and creatinine. Sooner or later, it's going to be a problem, particularly when you hit them with diuretics. Second, look for evidence of left-sided heart failure. And of course, we have it on the physical exam. It's wonderful when you can hear an S3, rails pulmonary edema on X-ray. But in chronic heart failure patients, the sensitivity of this goes down to 10%. It's very rare when you actually see this. So again, what will tell us is more symptoms of the patient that you got to ask them more so. Like they're tachypnic, they have smothering feeling. If they live in South, if they live in North, like in New York, they're gasping for air. Anxiety at night, and they cannot go to sleep. You don't know why. there's something, what it is, that's just sympathetic activation from fluid shift at night from the legs, and the patient doesn't know how to express that. They just have insomnia and keep asking you for Ambien. It was really an equivalent of paroxysmal nocturnal dyspnea. And on the echo, you can pay attention because we are going to put that in the report. They will have even if their EF is normal, they'll have pseudonormalization, which means a severe elevated left atrial pressure or restrictive physiology on the echo. Restrictive physiology does not refer necessary to cardiac amyloid, like we know, restricted cardiomyopathy. It refers to severe elevated left ventricular diastolic pressure, left ventricular mean diastolic pressure, and left atrial pressure. So it's actually bad news. It's probably the most negative prognostic sign that we have from the echo for patients with heart failure. So this, I hope that I convinced you that actually, once you have elevated right-sided pressures, not only that you have problem with the renal vasoconstriction that we have on the left side, and maybe low cardiac output, which comes late in the disease, but you also have renal vein hypertension that causes the inappropriate renal vasoconstriction and all the neurohormonal activation that you otherwise trigger just from the left-sided heart failure. So the approach with these patients who are incredibly sick and very difficult to manage, okay, is that really you have to use better vasodilators to work better on the right side. And sometimes we need to add inotropes, but it is my actual experience that actually, I add them there, the butamine Mirinon, but this particular patient actually was on inotropes, was on the butamine. It didn't do anything. What it did make a difference is actually Neseritide, which again, this is off-label, and it was anecdotal. I found actually the Neseritide works tremendously well for these patients in my anecdotal experience. And it actually makes sense because it's actually compared to nitro. It's like intravenous Viagra. It's probably one of the best agents we have actually to reduce the pulmonary hypertension, actually to reduce the right atrial pressure. So it's twice more potent to reduce the right atrial pressure and pulmonary vascular resistance for the right side as opposed to nitro, even max dose nitro. So for me, probably the way it worked was because I dropped the right atrial pressure, reduce the pressure gradient across the kidney bed. That also has some thoughts of, there is some evidence may improve renal perfusion. Then I hit with diuretic and the kidney opens up and actually can respond. That's one way. And you just gotta be careful. But alternative is we can try to remove fluid by all means by considering ultrafiltration, particularly if this patient is really having anasarca. And again, if they are candidate of dialysis, the best thing to do is to just call the nephrologist and let them dialyze them also if it's too late in the disease, basically. And really, that's all. It's not going to help unless you really think this guy is big belly, obvious got sleep apnea. You got to treat the underlying sleep apnea. And a lot of times we see these patients end stage, but there are many of them who I reset the clock, remove the 60 pounds, kidney goes back to normal, and they're outpatient once I treat their sleep apnea. I have a patient who has not been in the hospital for 3 years and was actually sicker than this patient. I need just 5 more minutes to convince you there is another entity that we see every day in the hospital that actually causes more renal failure, in my opinion, than any heart failure. And we kind of choose to ignore it, but I think it's really important to connect the dots. So that is what we call the systemic illness causing both kidney and heart failure. What I mean by that, I will use an example as a sepsis, but anything that causes systemic inflammatory response syndrome, like severe gout attack, UTI, URI that causes hypotension can actually lead to the same mechanism. So this is a 76-year-old Caucasian male from nursing home. Comes for 2 days worsening dyspnea, has been on some ACE inhibitor and Lasix at home, has a blood pressure of 98/40. So notice that mean arterial pressure is less than 65 here. So I know this, as soon as the map is less than 65, this kidney is underperfused by itself, will cause renal failure, even if there's nothing else there. Then you have tachycardia, you have a mild volume overload, which is pretty obvious. JVP is all the way up to the earlobe. You got a clear volume overload, orthopnea, but the patient, as opposed to the other patient, instead of being cold, like you would expect cold and clam with sympathetic activation, it's actually warm. Now, this makes no sense. Anybody who has seen somebody with acute pulmonary edema or heart failure, causing, pulmonary edema, they all get cold and clam because they have tremendous sympathetic activation. And now, if you're hypotensive because of heart failure, you better be cold and clammy. If you're not cold and clammy, that means there's something else going on, coexistent, that pushes, basically contrasts the sympathetic activation and makes vasodilation. And so immediately, patient was afebrile. Immediately, I thought this patient is septic, okay? Of course, the house staff did not believe me. So we put this, the patient had the BUN and creatinine ratio of 92 over 2.4. It was obvious oliguria towards anuuric, has a BNP level of 1200. All it means is being in heart failure with chronic elevated LVDP. Not much on the volume on the chest x-ray, not much interstitial pulmonary edema. EF is 25% with normal right ventricular function. So white count was normal. There was nothing there suggesting any infection. So to prove this, actually, I had to remove the patient in the unit, particularly with this hypotension, because I was actually thinking that, maybe we need to bring up the blood pressure instead of to improve the renal perfusion. So we actually swanned the patient. This is what the swan showed. Despite of looking in the most horrible heart failure with hypotension and having everything for that, actually the cardiac output was 6. The same patient with an EF of 25%. Systemic vascular resistance was low. That means the patient was inappropriate vasodilated systemically. So normal values in 1,000 range with severe elevated left-sided pressure too. Wedge of 24, CVP of 18. So these patients who we see every day in the hospital, they're also very difficult to manage. Both the pulmonary ICU team or cardiologists or the ICU hospitalists have to deal with this every day. My simple question is, these are the therapeutic options. What would you do for this patient who has heart failure, is volume overloaded, although not a lot, centrally, and is hypotensive with bad renal failure? Should we give fluids to the patient? Should we give inotropes? Should we give pressors, vasodilator, or consult renal because patient is going on dialysis? I'll give you, upfront, and I will tell you, this patient 4 days later was discharged home with normal kidney function. So we don't need to consult renal, okay? Not on this patient. But what I would like for you to take home is that you have to have a rational and goal-oriented approach with these patients. Otherwise, you can't win, all right? So my rational approach was that there is something else but heart failure that's happening here, and there is some kind of inappropriate vasodilator syndrome here, which is documented now by my SWAN numbers, okay? Number 2, so I need to treat that. My problem is that to treat that, I'll require pressors, which is against if I need to treat heart failure, which requires vasodilators or inotropes. So what would you do next? Would you give fluids? Who would give fluids to this patient? Raise your hand. The blood pressure is low, 98 over 40. We need to improve renal perfusion. Great. I was hoping you're not going to do that. Then who is going to give the inotropes? By the way, really, I don't see any problem with inotropes. If you want to give inotropes, the only problem is keep in mind patient's hypotensive mirinone is a very potent vasodilator, so I would choose the butamine until you figure what's happening. But you say, well, we don't need inotrope because cardiac output is 6, but so it's high, but maybe still not appropriate enough. How about pressors? Who would give pressors to this patient? Great. Good choice. Vasodilators? No way with that blood pressure, okay? But again, it's not the systolic that I'm worried about. It's the mean arterial pressure. And we know now, systemic vascular, the patient is too vasodilator. It's actually stealing away the blood from the kidney by blood going in the places that doesn't need to be, okay? So let's see if I can convince you that actually a very well-documented mechanism of actually acute renal failure in patient with sepsis is actually inappropriate renal vasoconstriction from the cytokines released by whatever sepsis mediators you have with inappropriate peripheral vasodilation, okay? And that's yet another mechanism. The reason why we need to know about this because the treatment is opposite to the heart failure, so we'll have to somehow balance those two opposite mechanisms. So first of all, let me show you the evidence for that this is what happens. First of all, I want to point out that progressive heart failure by itself, it's associated with progressive release of cytokines that are actually vasodilators. So look at this. The worse the heart failure, these are patients who undergo eventually heart transplant, the higher the production of TNF-alpha, the higher production of IL-6, both in plasma and in the heart muscle itself. That correlates with actually those patients who live around with a chronic elevated wedge or right side pressures are the ones who are going to have higher cytokines activation. And the interesting thought is that these are actually inflammatory mediators. So I will propose to you that any patient with advanced heart failure who develops renal failure, we shouldn't call it cardiorenal syndrome. We should call it cardio-inflammatory renal syndrome, because this could be actually the key why in advanced stages these patients are so fragile to the renal function. The second thing is that now on top of that, I am developing a condition, a UTI or gout attack or something that does exactly the same thing. The only difference about 10 times higher. So look what happens if you measure the cytokines level in somebody who has just UTI, which is lower level, just bladder UTI versus acute pyelonephritis. This is a study that was done in children, but does make the point that in your healthy control, you have almost very minimal or no cytokine release in your urine or in the plasma. With lower UTI, immediately goes up, all these cytokines, they go up by 6-fold. And then, of course, if you have acute pyelo, it can go up about 20 to 100-fold. Okay, so you have already, if you already have prior chronic heart failure that's actually advanced, you already have 2 or 3 or 5-fold higher levels of those cytokines, then you get a condition that does that by default, another 10-fold. Even if you don't have acute pyelonephritis, okay? Acute pyelo means that the bug infected the kidney, okay? But lower UTI, the bug just infects the bladder. By itself won't cause renal failure in me and you walking around. But indirectly, through the cytokine release on a prior kidney that is already seeing elevated cytokines, then look what can happen. In your kidney is going to actually, what's interesting is the peripherally, in response to TNF-alpha and IL-6, will actually vasodilate, because the TNF-alpha, interleukins, all these guys that actually release, upregulate the inflammatory nitric oxide symptoms and actually cause more nitric oxide release. And it's like you give IV nitro to this patient, and it's very potent to actually to cause inappropriate peripheral vasodilation. The funny part, the same cytokines that do that in periphery actually cause vasoconstriction in the kidney. Okay, and so while the reason why the BN creatinine ratio goes up is because while the periphery is super vasodilated and the patient looks fine with the brain and with the skeletal muscles, it's actually very vasoconstricted at the kidney level. It doesn't take much to develop ATN. Okay, and TNF-alpha actually by itself and all these cytokines have been in the basic science studies have been shown to mediate every single renal insult you can imagine, almost independent of the etiology. Renal ischemic perfusion, diabetic nephropathy, contrast nephropathy, every version that we know hurts the kidney, whether it causes or not ATN, actually one way or another is mediated through the TNF-alpha. And one thing that is very important is that not only, just to make a point, these cytokines are not released just in UTI, not only in the URI. They're also released in a severe gout attack. You see here is the level of, the labels, here, TNF-alpha and IL-6. This is osteoarthritis or chronic osteoarthritis, a control patient. They have some baseline elevation of this, so we know it's a chronic inflammatory state. If you have a gout attack, they go immediately up, and if you have rheumatoid arthritis, just to compare as a positive control, they're way higher. So these patients, these mediators are released in a lot of little SIRS-like states. So each time you see the patient is warm, has SIRS-like, start to do the search for the SIRS. I ask them if their joints are aching, particularly they're 4 or 5 days after you diurise them. That's what usually happens. If they had a Foley for 5 days, usually by exact when you're about to send the patient home, day 5, a third of them, they will develop UTI. So then you understand why I have a battle with the Foleys for these patients. Okay, so I'm going to wrap it around, and I'm going to give you an advice for these particular patients, for this group. If the patient develops renal insufficiency and it's warm, okay, think immediately there is something else causing the renal dysfunction, not just the heart failure, but of course it's contributing. This is, as long as the patient is comfortable, actually I stop treating heart failure. I'm going to concentrate first on treating, identifying and treating aggressive in the underlying SIRS condition. So number one, the worst you can do is to give them vasodilators, okay? And let me show you why. This is a study that was done by Dr. Guyton, the Guyton, 30 years ago, where it showed that actually if you have me and you normal people, if we drop the mean arterial pressure, the GFR starts to drop down only when the MAP gets lower than 65. That's why you have all these sepsis protocols, titrate the pressures to MAP more than 65. However, if you have sepsis, or you have sepsis and the patient actually is concomitant on vasodilator like an ACE inhibitor or an ARB, actually that curve shifts to the right. The GFR stops to drop even when your MAP is 80. So in other words, to regulate the renal perfusion pressure, the kidney is using the local activation of angiotensin II, which you do not want to cut that off. And those patients, if you were to use an ACE inhibitor on ARB, you'll have to make sure that you put them on pressor to have a MAP at least 80 or even higher. So the number one rule is, those patients, if they're comfortable, I don't treat their heart failure. They're warm. I actually stop all the vasodilators. And of course, Natrocor, nitro, everything else, every vasodilator will be contraindicated by for this patient. You're going to steal away the blood from the kidney. You're going to make worse. So I stop all that. Number two, I postpone the diuretic use. Diuretics will do exactly the same thing, more neurohormonal activation and worse, unless the patient is about to go on the breathing machine. And I really think about SIRS, and I start to investigate that. Third, whatever I do immediately, I try to keep the MAP over 65. So if the MAP is consistently below 65 over 2 hours, I move them in the unit and I put them on pressors actually to raise the MAP, to have appropriate renal perfusion while I'm trying to buy time to figure what's happening. And third, of course, diagnose and treat the underlying etiology, gout, UTI, URI, whatever is there. Okay, so the final approach now to integrate all of this, what I do every day in the practice, I see this kind of patients, I ask myself, what is the volume status? If the volume is up, that means I need to remove the volume. If the volume is down, I need to give volume. What is the perfusion status? Is warm, cold, or combined when you have both actually sepsis and some kind of heart failure? Then I think, is it left side heart failure or right side heart failure? Then I look at the renal function. And then I am very paranoid and suspicious of some underlying acute illness that can aggravate this. See, all these classifications of cardiorenal syndrome are wonderful, but they never take into account what we have to face every day, that you never have just one condition in those patients. You always have a little heart failure, a little sepsis, or a little heart failure, and gout. And that's where I think it helps if you understand each of them separate and then take them together. And to wrap this up, really, I showed you how you treat the cardiorenal syndrome based on left side and right side heart failure. Of course, one of the side effects of diuretics, the way you can induce cardiorenal syndrome is actually you over-diurese the patient. But I never over-diurese the patient unless they really look dry. So if you think that if you see a lot of volume still on board, obvious, that's not the mechanism here why the patient is developing renal failure. And number two, if they were over-diuresed, they'll also be hypotensive or orthostatic. That will precede by 1 to 2 days actually developing renal failure. That's for the house staff. And then really the key with the hypotension from vasodilation, hypotension per se, MAP less than 65, will cause renal insufficiency. So if they are vasodilated, make sure you don't have particular house staff. Don't keep the patient on the floor at night with over 2 hours of MAP less than 65. You know they'll have tomorrow creatinine double. Move them to the unit, raise the blood pressure until you figure what's happening, put them on pressors. And unfortunately, you cannot do that on the floor. So, other issues I haven't addressed here, but anyway, remember that, believe it or not, although these are completely different mechanisms and entities, they all look exactly the same when you send the test pre-renal azotemia on the UA. And it's no wonder that the doctors are very confused and are starting to use opposite treatments for opposite diseases. So this is just a common denominator. I want you to do a differential workup and think through that and ask the other services what's happening. Okay? And this is what I do. If the patient has heart failure and has renal insufficiency, I look if the patient is wet and warm. And if the MAP is less than 65, that means the kidney is underperfused and the patient is inappropriate vasodilated. I start to think sepsis, SIRS, or whatever. And if the MAP is for more than 2 hours, less than 65, I move them to the unit. I put them on pressors to buy time to figure what's happening. If the patient is wet and cold, that means systemic vascular resistance is high, right? So then I look at the MAP more than 70. That means that vasodilators is a first line. And don't even bother with PO diuretics. You're diuretic resistant. You're going to waste your time and you just cause diuretic resistance without actually, and neurohormonal activation without actual diuresis. No benefit from inotropes in general if the MAP is over 70. Now, if the MAP is less than 65, they're cold. This is a true inotrope deficiency and low cardiac output state. You got to put first them on inotropes and then you have the vasodilators after that. And there are some other tricks you can do without diuretics, but that will take another whole hour lecture. And keep in mind that the high-risk patients are those that I just went over, and particularly when they tell you on the you see that they develop this cardiorenal syndrome with pre-renal azotemia-like picture with severe right ventricular dysfunction, severe concomitant valvular disease, refractory heart failure. Each time they tell you they're every 2 weeks in the hospital, you know it's bad news, and severe volume overload. Because remember, you cannot normalize the cardiac feeding pressures until you first normalize the volume status. And I'll be happy to take any questions.